Hello everyone. First of all, I tell thank you for subscribing my channel and it's 100 subscribers now. Thank you so much. Today we are going to discuss about the humerus, its site determination, features and attachments. First we will discuss about the site determination. As we know, humerus is the bone of arm and it is the longest bone. Site determination. For side determination, the upper end is rounded and the lower end is expanded form from side to side, and it is flattened before backwards. The head is directed medially upwards and backwards. The lesser tubercle projects from the front of the upper end and is limited laterally by the intertubercular sulcus. It is also known as bicipital groove. Next, we will discuss about the features. In features, first we will discuss about the upper end, then shaft and then lower end. In upper end, the main points are first, as I told earlier, the head is directed medially upwards and backwards. It articulates with the glenoid cavity of scapula and forms the shoulder joint. Next, in upper end, we have three necks, that is anatomical neck, morphological neck and surgical neck. First, anatomical neck. The line separating from the head and rest of the upper end is called as anatomical neck. And morphological neck lies at the junction of convex end of diaphysis with concave end of upper epiphysis. And this morphological neck will disappear in adults. The surgical neck. The narrow line separating the upper end of humerus from the shaft is called surgical neck. And in upper end we have two tubercles, that is greater tubercle and lesser tubercle. The greater tubercle is an elevation, forms the lateral part of the upper end, and this greater tubercle has three impressions: upper, middle and lower. Next, lesser tubercle, it is also an elevation on the anterior aspect of the upper end. Next, we will discuss about the shaft. In shaft we have three borders and three surfaces. Three borders are anterior border, lateral border and medial border. The anterior border, upper one third of the anterior border forms the lateral lip of intertubercular sulcus, and the upper part of the medial border forms the medial lip of intertubercular sulcus. Anterior border forms the lateral lip of intertubercular sulcus, and medial border forms the medial lip of intertubercular sulcus, and the one more border is lateral border. It is prominent only at the lower end where it forms the lateral supracondylar ridge. Next, we will discuss about the surfaces. Three surfaces: anterior medial surface, anterior lateral surface and posterior surface. First, anterior lateral surface. It lies between the anterior and lateral borders, and the upper half of the surface is covered by deltoid muscle, and there is a marked V-shaped deltoid tuberosity. Next, we will discuss about the anterior medial surface. This lies between the anterior and medial border. Anterior lateral is anterior and lateral, anterior medial is anterior and medial. Next, the upper one third of these forms the floor of the intertubercular sulcus, and in anterior medial surface there is a nutrient foramen is seen in the medial border below the it. Next, the posterior surface lies between the medial and lateral borders. Next, we will discuss about the lower end. The lower end of the humerus forms the condyles which expand from side to side and has articular and non-articular parts. First, we will discuss about the articular parts. There are two articular parts, that are capitulum and trochlea. The capitulum is a rounded projection which articulates with the head of radius. Next, the trochlea. It is a pulley shaped surface and it articulates with the trochlear notch of ulna here in elbow joint. Next, we will discuss about the non-articulating part. In non-articulating part we have a medial epicondyle, lateral epicondyle, medial supracondylar ridge, lateral supracondylar ridge, coronoid fossa, radial fossa and olecranon fossa. First, epicondyles. Medial epicondyle, lateral epicondyle. Medial epicondyle, it is a prominent bony projection on the medial side of lower end. Next, lateral epicondyle. It is smaller than the medial epicondyle and it is anterior lateral part, has a muscular impression. Next, supracondylar ridges. First, medial supracondylar ridge is a similar ridge on the medial side. Next, lateral supracondylar ridge. The sharp lateral margin just above the lower end is called lateral supracondylar ridge, whereas the sharp medial margin just above the medial lower end is called medial supracondylar ridge. Next, coronoid fossa. It is a depression just above the anterior aspect of the trochlea. Next, radial fossa. It is also a depression present just above the anterior aspect of capitulum. Coronoid fossa is a depression above the anterior aspect of trochlea, whereas radial fossa is a depression above the anterior aspect but capitulum. Next, olecranon fossa. It lies just above the posterior aspect of. Now we will discuss about the attachments. First we will discuss attachments according to first upper end. Upper end we have two tubercles, no, three tubercles, greater tubercle, lesser tubercle and intertubercular sulcus. First, for lesser tubercle, the subscapularis muscle is inserted as shown in the diagram. Next, for greater tubercles, three muscles are inserted. First one is supraspinatus, infraspinatus and teres minor. The supraspinatus is inserted into the uppermost impression on the greater tubercle. Next, infraspinatus is inserted into the middle impression on greater tubercle. The teres minor is inserted into the lower impression on the greater tubercle. As I told earlier, in the greater tubercle we have three impressions: upper, middle and lower. For uppermost supraspinatus, for middle infraspinatus and for lower teres minor. Next, intertubercular sulcus. As we saw in borders, first pectoralis major is inserted into the lateral lip of intertubercular sulcus. Next, latissimus dorsi is inserted into the medial lip of intertubercular sulcus. Next, teres major is inserted into the medial lip of intertubercular sulcus. Next, in intertubercular sulcus we have contents. Insertions: long head of biceps brachii and its synovial sheath, tendon of long head of biceps brachii and its synovial sheath, and ascending branch of anterior circumflex humeral artery. Next, deltoid muscle is also inserted in deltoid tuberosity. Next, border, coracobrachialis is inserted into the rough area on the middle of medial border. On medial border, coracobrachialis is inserted. Next, brachialis muscle. It arises from the lower half of anteromedial and anterolateral surface of the shaft. Next, brachioradialis. It also arises from the upper two-thirds of lateral supracondylar ridge. Next, extensor carpi radialis longus. It arises from the lower one-third of lateral supracondylar ridge. Next, pronator teres. It arises from the lower one-third of the medial supracondylar ridge. Extensor carpi radialis longus and pronator teres. Brachioradialis and extensor carpi radialis longus. These two arises from the lateral supracondylar region, and pronator teres and superficial flexor muscles arises from the medial supracondylar region. Superficial flexor muscles, these are origin from the anterior aspect of a medial epicondyle. This is also called as common flexor origin. Next, the superficial extensor muscles of forearm and supinator have common origin from the lateral epicondyle. This is called common extensor origin. Superficial flexor muscles, common flexor origin. Superficial extensor muscles, common extensor origin. Next, anconeus muscle. It arises from the posterior surface of lateral epicondyle. Next, triceps. Lateral head of triceps brachii arises from the oblique ridge on the upper part of the posterior surface above the radial groove, and its medial head arises from the posterior surface. Next, capsular ligament of shoulder joint is attached to the anatomical neck, except on the medial side where the line of attachment dips down by 2 centimeters. Next, capsular ligament of elbow joint is attached to the lower end along a line that reaches the upper limits of the radial and coronoid fossa anteriorly and olecranon fossa posteriorly. Coronoid fossa anteriorly and olecranon fossa posteriorly. In next class we will discuss about its ossification and clinical anatomy. Thank you. If you have any doubts, let me know in the comment box. Please like, share and subscribe.